Good morning, everyone, and thank you for joining us to our international rounds. It's my great pleasure to introduce Dr. Andy Lorts, who is the director of the VATS program at the Cincinnati Children's Hospital, and she's going to talk today about ACSD and ventricular assist device. So I cannot think of anybody with more experience than Dr. Lorts to speak about this topic. And Andy, thank you for accepting the invitation, and the floor is yours. Looking forward to your talk.
Thank you for having me. I'm not completely familiar to go to a meeting, so hopefully it works for me. Had a couple of technical issues earlier. So thanks for allowing me to speak on this life-saving therapy for ACHD. I think it's really an exciting topic. It's, the next 5 to 10 years will be so different than where we are now. I kind of think of this picture as, the life-saving of all of the ACHD folks that may come out into their 30s and 40s and 50s and then need some kind of device. And we obviously know that transplantation is probably not going to be the answer because there is obviously a paucity of organs, but also we're not increasing that donor pool as much as we are the recipient need. I'm going to really quickly tell you a couple things about action just because I reference it a lot and I realize that there might be people on the phone that don't know what it is and may think, what is she talking about as I go through my talk? So really quickly, I'll tell you that Action is a learning network that has 68 pediatric centers. We do have a global presence and we are starting to onboard many international sites as well. Your pediatric site has been part of Action since the very beginning, and Amer's one of our esteemed Action leaders, so he could tell you more about it. Our principles of Action have always been that we're going to focus on the outcome of heart failure kids, we're going to use technology, and we're going to do whatever it takes to solve a problem. In some cases, that's retrospective data review from a registry. Some cases, it's a prospective trial, which we're involved in right now. Sometimes it's quality improvement, but whatever problem faces us, we will be focusing on. And you'll see through this talk with ACHD and Fontan that there's many times Action has taken on a stance about what to do with the congenital heart disease population. And so that's why I bring it up so you kind of know what this group is. There's 1,600 people involved in Action right now. And our solution for all of this was that we were going to get all these people together, but it not only was going to be providers, but patients, the institutional administration, industry was involved from the very beginning and has really helped us get off the ground. And we've convened into this group that is really focused on getting better outcomes for patients that need device or need heart failure therapy. These are the sites. I kind of told you all of this. Our patient populations right now are heart failure, which is mostly medication related, ventricular assist device, there's a muscular dystrophy arm of Action, and then there's a Fontan circulatory failure. We've done all of these different things, all different parts of research to try to get to the problem. And so with much ado, I'll now start talking about ACHD and VAD, but just so you know, when I referenced Action, it is this community of multiple people and multiple sites. And a lot of the work and manuscripts have been done by others than me, but I will present on their behalf. So we're going to talk a little bit about challenges in ACHD. I focus a lot on Fontan because I find that when I think about ACHD, besides the issues between pediatrics and adult and who takes care, a lot of the same issues pertain to the adult congenital patients that have biventricular circulation. But when we start thinking about Fontan circulation, that becomes very different. And so I am going to talk a lot about challenges with Fontan VAD. Patient device selection, once again, focusing on Fontan, just thinking through a lot of the same issues for pediatrics and adults exist in the biventricular circulation. We'll look at the data. And then I have 2 cases at the end if we get time. So our challenges have been, and this is just to set up kind of what we all are thinking, is that who will benefit from a VAD? Do we even know? Do we know what Fontan will do well with a ventricular assist device? Do we know what type of VAD we should use? Is there the right VAD? Well, I'll definitely say we know that's not the case, that we do not have the right VAD yet. We have things that we can jerry-rig and things that we can use in different ways, but most of the time we really don't have the right support device for many of these patients. And destination therapy is kind of an old word. We're starting to use chronic therapy instead of destination therapy. It's something that the patients and families don't love, the destination word. But can we use these therapies, what we have now and what we'll have in the future, as kind of a chronic therapy that will be the last therapy for these patients instead of transplantation? And then what are the barriers to referral to the advanced cardiac therapies group? And all people call these groups all different things. You know, it used to be called heart failure. Definitely families don't like that. So most of the time it's called a kind of advanced cardiac therapies, and that includes transplantation, but also includes, you know, how do we use cardiomems different? How do we use that Farxiga in these patients? So some of the new heart failure meds, and how do we get these patients to a heart transplant, and do they need a heart liver? And can we prevent them needing a liver transplant? So lots of things to think about, and lots of things to think about at your institution about when to refer these patients. I think the opportunities to improve outcomes include, and I mentioned some of these, that we need earlier referral. And this earlier referral is a really, the words aren't right. We need to think of a new way to state it. It's really a collaboration. It's not we refer the patient to heart failure and say, you know, congenital heart disease is done with them. It's more of how do we work together to make this better. Increased experience with mechanical support, of course, and how do we reverse end organ dysfunction? And can we reverse the end organ dysfunction? And then can we use VADS as destination? And then just, you know, below, I think I've said this, but so important is how we foster this environment that it's not VAD transplant and congenital ACHD, but how we bring those two teams together. An important concept to think about, and I think about this all the time, is that for DCM, VAD survival is now similar to transplant survival at 2 years. You can see there heart transplant survival is 82%, and HeartMate 3 LVAD survival was 79% in 2019. I would argue that now our HeartMate 3 survival is even much better than that. And in pediatrics, 2-year survival is 85%. And so we're getting close to the time where we say, you know, 2-year survival at least is similar in a VAD than it is to transplant. So should we really be pushing forward? I would say we have a little ways to go with the Fontan population, but I will show you those numbers. They're getting close to heart transplant survival numbers. And could we give these patients at least a couple years before we either needed to transplant them, or maybe that is the next, you know, their final 2 years if they're not transplant candidates. And I say final 2 years, that's just on average, but we have had HeartMate 3 Fontans. I had one who was on for 7 years and have a mustard on right now who's at 7.5 years and still followed in our clinic with a HeartMate 3. Is there a future that we can achieve better outcomes with devices and transplantation? And I bring this slide up because I think we really need to think through that may be the next step for these patients, because I really don't think we're going to have the organ availability that we need for transplanting many of the Fontans that have failing physiology. So what are the options for advanced therapies for ACHD? This is no news to anybody here, but just to say again, you know, dual organ transplant, heart transplant, probably not going to be the answer. VAD as chronic therapy may be the answer if we understand it better and we get the right patient selection and possibly a new device. But we can also do VAD to heart and VAD to heart liver. And so we have had success doing this, and we actually prevented what we think we prevented, needing a liver in one patient that we felt like we had improved liver function after the VAD was in, and we did just go straight to heart and did fine. I can't tell you what they would have done with a heart liver or how they would have been, but they did go from VAD to heart only, and we were able to transplant them quicker. So just something to think about. Are we at a stage where we really need to know if reversing that liver dysfunction is possible? So patient selection, this is also no news to this group, but just to say, when we're thinking about VAD, we're thinking about, is it right-sided failure or systemic ventricular failure? Usually when they come to my clinic, I'm hoping that it's some ventricular dysfunction. You know, I look at the schedule and I'm like, okay, they have an EF of 20, that's good. Because we really don't have good right-sided device support. And so thinking through, are they going to be okay with just a systemic ventricular device, or are we not going to have that forward flow from the right side? Right-sided failure is complicated, as you all know. You have all of these symptoms, and we don't have a great device. I'm showing you this. This is a Berlin aortic graft that can be put on the right side in older, bigger patients in Europe. It's not available in the United States, and I'm pretty sure it's not available in Canada, although there could be different regulatory paths. And we are thinking about how to get it to the US. And it's a cannula that will help drain that right side to a Berlin heart. The obvious issues are, one, that it's not easy to implant. Two, you're stuck to a Berlin heart in the hospital. And so this is not something that is going to be our answer to right-sided failure, but could be a short-term answer where we can start to learn about decompressing that right side and how that will look. My guess is that left side will not tolerate, your systemic ventricle will not tolerate that improved flow very well, and you'll end up on a BiVAD. So these patients could end up with two big Berlin hearts because they're older patients, and stuck to an ICUS in the hospital. So not ideal, but maybe the change in physiology with this VAD type will help us learn more. Combined right and left-sided failure, I kind of talked about this. There's oftentimes that just a SVAD will not help. This is a figure from Ryan Davies in Texas, very complicated, more of a pediatric patient that he did, making this graft here that was going to drain the right side, similar to the graft that is now available in Europe in bigger sizes for bigger kids with the Berlin heart. And then what about, so once again, this is the Berlin cannula. This is the cannula that is surgically implanted, draining that SVC and IVC to this Berlin heart. So once again, not perfect by any means, may help the physiology in bigger patients. It's only available in a very large size. But we could learn from this and understand more of what we need in the future. And then there's the Syncardia, and I just show this picture to remind everyone that the Syncardia total artificial heart, this is really one of the only times I bring it up in this talk, although I think it is a good device and you guys have used it successfully there as well. You do have to have two inflows. So if this is your systemic ventricle, you have to kind of develop a inflow on the right side to sew in the biventricular artificial heart. So not perfect, and it's been done only a handful of times on a Fontan circulation, and about half were successful, or less than half were successful, to get the patient to transplant. So not an ideal situation either. So we really don't have good biventricular support for the Fontan, and definitely not the right side. We have done a lot of work. This is a subpulmonary VAD meeting summary, too small for you to read, but to know that Action has really taken on this issue to say, what do we need to tell industry and the FDA and the investors that we really need for a Fontan VAD? What is it that we're asking for? And this is kind of what we came up with the final need statement that is going out to industry and engineers to really say, this is what we think we need. This is what we think will happen if we do this, so that everyone's kind of aware of this problem. But systemic ventricular failure, as I said, gets much more exciting because there's something that we can offer to help these patients. When they come to my clinic and have dysfunction, these are kind of the questions that I'm asking. Is the pressure high enough in the ventricle that lowering the EDP help the Fontan flow? Many times this pressure, there's no exact number, but we're thinking at least 14 or greater, and we can unload that ventricle to make the Fontan flow better, as well as get more cardiac output. Thinking, is the Fontan circulation without a VAD filling the ventricle? What's the pressure on the right side? If we don't do anything with the right side, will the left side device fill? Those are kind of questions that I'm thinking in my mind. Or is there too much obstruction somewhere that we have to take care of that before we put an SVAD in? So second question. And that I kind of combine the second and third together, but anatomic issues, and are they minimal? could we stent the Fontan? Could we stent the PAs so that we can just put this SVAD in? Or is it going to be more of an extensive surgery, which then leads to the bleeding and all the issues that could go with the SVAD? You want to do the least amount possible when you're in the operating room putting in an SVAD because of the bleeding risk. You don't want to have to be redoing the Fontan or the PAs at the same time. So kind of thinking through what that surgery would look like. What we really want it to look like is this guy right here. So this guy was on for 7 years. He was our first HeartMate 3 patient, the first HeartMate 3 ever Fontan patient. He was 24 at the time. You can see his hemodynamics after the implant were perfect. His sats came up really nicely, so we know that his saturation issue was a mixed venous issue, not anything else. We know his CVP came down very nicely, and his atrial pressure came down as well. This is not how they all look, of course, and you guys know this because I know that you have experience with some of this, but this is the perfect example of what we would love to see in our Fontan patients. This decreased, I don't have Fontan pressure on here, but this decreased his Fontan, well, CVP's there, pretty dramatically, and he was able to extubate and get out within 7 days of the hospital. He chose to keep his HeartMate 3 for 7 years, and so he finally went to transplant, but he did really well with his VAD. Patient selection for VAD is interesting because we say all of these things about patient selection, but none of them really hold true for Fontans. We say, you know, you should put a VAD in when they're unresponsive to medical therapy, escalating inotropes, and then you don't want them to have end organ dysfunction. But the Fontans, you know, your liver is not normal. Many times they have renal dysfunction. Oftentimes they're frail. So just thinking through, maybe the selection for VAD in general is not completely right yet for the Fontan population. You know, how bad is the liver to actually, will the liver do okay through surgery? Will they be vasoplegic, or is the liver going to respond well to unloading and get better? And then thinking about our old-fashioned VAD contraindications, I say this because in pediatrics, we often say, you know, these are the reasons why you wouldn't put on a VAD. But all our Fontans have some kind of clotting bleeding disorder. So we have to kind of change that thought process. Many of them have irreversible end organ dysfunction. Is the liver disease reversible or not? I mean, I think we don't know. And how much of it can we make better? So I find these are a little bit old fashioned, and maybe we need to change these for our single ventricle population. And then surgical fit, you know, using your CT scans in these complex congenital kids to figure out what device will fit and how it will look in the chest. And this is a Heartware, which is no longer available, but this is a Syncardia, and this is just kind of trying to fit what size device could fit. And then also when you're doing single ventricle and thinking about single ventricle Syncardias, where are you going to put the pumps? Where are they going to sit? How are they going to be connected? And then, you know, I mentioned this, but are they a VAD candidate at the time of referral? I mean, we really do need to think through getting them to us earlier. And that is an art, not a science. How do you get them to you earlier, but not too early where they lose their initial cardiologist? I think there's a lot to be done here. I think this is a whole field to think about. Are there specific criteria that should lead to referral so you don't miss that window? The devices available are limited, and I mentioned this earlier, but you know, if you come in shock, you could do a Centromag, you could do an Impella, which is not on here, but there are reports of Impella in Fontan, and they are successful for short term. The Berlin heart may end up being something that you could do on the right side if we can get access to the cannula. The Heartware is now gone. The HeartMate 3 is your SVAD that will be give you tons of flow and offload that Fontan like crazy. We often do things a little different in Cincinnati on our Fontans, and we flow them as high as we possibly can. Some people feel like that's going to overload the Fontan circuit, and we have not had any of that experience. But what we've seen is flowing them as high as we can, we're able to offload get rid of collaterals. They actually close. We are able to give really good output to the end organs, and we think they do a lot better. And so we turn them up until our patients often say, so we're flying off the bed. But just to think through, like, how much flow can you really get from that circulation to lower that end diastolic pressure? So this is a really good device for your adult Fontan with dysfunction. And then there's the combined failure. All we really have right now is the syncardia. Eventually we're going to have something to put on the Fontan side. There's multiple devices coming down the coming through the labs that I think will make it. It's just that we don't have it right now. And maybe the Berlin cannula will help us for the short term. Perioperative considerations for the Fontan. We believe that fenestration is helpful. It does help fill the SVAD postoperatively. This is not done at every institution, but in Cincinnati, we do fenestrate, or make sure if there's a fenestration, we leave it. If there's not a fenestration, Dr. Morales will make a fenestration. We do think that really improves that SVAD flow, and they really aren't too blue. They end up being much pinker because of their cardiac output. And so we've had good success with that. And it just depends on what you feel is more important. If you're going to be a little desaturated but fill the VAD really well, what's the risk? They're going to be on tons of anticoagulation anyways, so it's not necessarily a clot risk. We use really high cardiac index to improve end organ function, and then we start to come down as they mature with their VAD. We have seen a lot less collateral burden when we go to transplant after years on device. And so we're starting to collect that data to see what that looks like. But is it that with such good cardiac output, they're just making less collaterals? But there's been lots of comments from our surgeons that what they're finding is looking much better and easier to deal with at transplantation. Rehab and discharge, there is some action materials that if you don't have, we can get you access, but there's journey maps, there's everything you can imagine for ACHD patients, just to walk them through what this looks like if they do get a VAD, how do they get home, thinking about getting them really good nutrition and physical rehab, so that they can be a transplant candidate if that is what they're going towards. I think this is a really important concept when you think of your patients. And, we try not to use the bridge term anymore. So bridge to transplant, bridge to destination, bridge to whatever it is. It doesn't really matter. It's really just a way to treat heart failure. And if you don't think of it as a bridge, you can decide where you're going to go later. So if you treat their heart failure, make them a better candidate for something, maybe they will become a transplant candidate, or maybe they will want their VAD longer and there'll be chronic therapy. But I think it's really important to let your patient and your team change paths. So we don't do a full transplant evaluation before we go to VAD. We say, we're going to treat your heart failure. We're going to get your end organs better. We're going to make you be able to have clear thought processes because you're going to have good cardiac output. And then we'll talk about next steps. Maybe you'll be a transplant candidate, maybe you won't. So I think that's an important thought at each program to think through how they want to do this. Most programs still do a transplant evaluation before their VAD, and I think the patient probably doesn't feel great, maybe doesn't know what you're talking about because they're just don't have clear decision-making capabilities. And maybe it's that supporting them getting out of the hospital, getting them better nutrition, and then starting to talk about the next steps, maybe better. Just depends on the patient and the institution. And then exception for adult listing, I put this in here and then kind of forgot that it was Canada, so it's not relevant to you all. But for the US listing, congenital heart or Fontan with a VAD does become one of our highest status. Not that I believe that should be the case because they're actually looking really good, but because it was made years ago when that wasn't something that we did a lot, that has made them a status 2 now. So let's look at the data really quick. So VADs in Fontan patients, and I kind of mentioned I was going to focus on Fontan just because it's easier to think through the data on the Fontan patients than all the adult congenital. But this was our first set of action patients with Fontan, and this is their survival outcomes. And this is all comers, but it was 80% alive, transplanted, or on device at 1 year. So I think this is important. This is getting close to what we see in the dilateds. And so their outcomes are starting to be better. Once again, a very mixed population of Fontan patients, but we do have new data coming soon. I'll show you a little bit of it. So what do we see in these Fontan patients? This is the same paper, just showing that the Fontan pressure comes down in most of these patients. Once again, very small, just we didn't have caths on everybody, all of the 40, 50 patients, but just to give you the ones that we did have good hemodynamic data, change in the capillary wedge pressure. So on average, you know, we were seeing a change in the pressures that we really want to see. The follow-up analysis, Intermax and PDMax, pulled their Fontan data. It actually is probably about the same patients, 55 patients with a positive outcome of 81% at 6 months. So very similar to what the action data showed. So we have two registries. At least we can show consistency. And then Cincinnati Children's data, you know, we did our 9 patients series a couple years ago, looked at the albumin stays about the same. Bilirubin comes down nicely. Renal function seems to, at least if they didn't have renal dysfunction, kind of settle out, and your BNPs are coming down to single digits, really. So we saw some good results with our offloading these patients. Once again, these are SVADs that have some kind of ventricular dysfunction, not diastolic dysfunction, systolic dysfunction. And so we are really limited by what we can do with just diastolic dysfunction. And VLAD flows, I mentioned this, but coming down through the time on device as the collaterals start to go away or they have less collaterals, we're able to kind of decrease their flows. But their cardiac index at the beginning of the run is about 4. And so this is under review, not yet published, but the next Fontan series, which is about 100 patients, shows a 6-month survival of 78% on the HeartMate 3. And so now we're able to we have more patients, so we're able to kind of get rid of the Berlin patients and really look at these HeartMate 3 patients. And you can see that their survival is pretty good at 6 months. And so we're making progress in this group of patients. And I think we're learning a lot by sharing our experiences. And I think we'll continue to get better. So hopefully in a couple of years, we'll even show a better survival rate. And not yet adjudicated. This is from our action dashboard. I just used the filters to figure out congenital heart disease and adult size, and there's 105 with a mortality of 16%. So if this holds true, this is, you know, an 84% survival. So we do think we're getting better. And important to think about is that both with MCS and transplant, it's this beginning time period that the patients are at risk. And so always thinking like, what can we do to make them the best candidate before their VAD or before their transplant? And this probably links to earlier referral and not getting the patients to MCS and transplant too sick. Once again, no one has the exact, you know, answer to when is too sick and when is the right time, but we've got to try to figure that out because that will prevent these deaths here, as well as you see this blue line is ACHD. This is a like early death that if once we get this line up, we should be traveling right along the non-ACHD patients. Once again, same with transplant. So patient referral, I've talked a lot about. I'm going to mention a few papers and then we'll start to talk about some cases. So there's 2 papers from Action recently that came out. That one is about outcomes after initial heart failure consultation in Fontan patients. This was a QI initiative that we did that was really focused on, can we get these patients to a heart failure clinic earlier? Can we collaborate together to make this a better system? And not that it's just a referral and then the adult congenital lose their access to caring for that patient, but a collaborative group that figures out what's the right time to take them to the next step. With this data collection, we found that over a third of the Fontan patients seen for initial consultation have a really dramatic care escalation within 30 days. So they were either admitted for milrinone or went to VAD or were listed for transplant. And so that's obviously not where we should be. A third are getting escalated so quickly. And 12% of Fontan patients were referred too late, according to the advanced heart failure therapy physician taking care of them, and were not a candidate for VAD or transplant. So once again, a pretty big number, a pretty big percent of patients, 30% escalated and 12% not a candidate. Fontan patients with early failure, not really relevant to this group because yours are going to be older, but they did not do well. And if there was a consult, the first consult was an inpatient admission, more of those patients were deemed too sick for advanced heart failure therapies. So somewhere there's the right time that might be before admission, sometime before care escalation at 30 days, thinking through what those criteria should be, and how to continue to see them together. And I know we've struggled with this in Cincinnati, and we now have many patients come to heart failure that aren't ready for any advanced therapy necessarily. And then we work together to change their medications around or wean their steroids, or we talk through like, okay, this patient smokes, so they're going to need to be 6 months from nicotine. So let's start this now. And it really has allowed us to have more of a collaborative approach. There's many patients that don't go to VAD or transplant in our heart failure clinic, but are there to kind of come up with the next plan for the next couple years. And then another paper by Action, Considerations for Advanced Heart Failure Consultation in Individuals with Fontan Circulation. There is a recommendation paper, and there on the Action website, there's a list of the criteria that there was a consensus group that came up with, that we would like to see the patients when they develop X, Y, and Z, and trying to see if those action criteria will help with decreasing the number of referrals that are too late. And a lot of people ask us, why should we refer? And I've mentioned this many times, but getting to know the patient and family is important, and we've gotten a lot of feedback from families about that. New heart failure drugs are coming on the market that a lot of the heart failure physicians are really getting excited and knowledgeable about, and maybe they would help the Fontan population. Device options are changing, transplant criteria change. And so just kind of trying to figure out at your own team, like, what are the things that you can do together? And this is just a patient quote, just thinking through, like, can we build a relationship with both teams so that we're not rapidly going to a team that we don't know? There's lots of resources for providers on the Action site. If you have any trouble and you want any of them, we could help you get to them. There's some consideration for advanced heart failure. We know that this is not perfect, and this is going to continue to be revised as we learn. There's also a Fontan Grand Rounds deck, if you want access to it, that kind of walks you through all the outcomes of transplant, etc. So we're going to switch gears to two quick cases. The first one's a Fontan, just to go with our Fontan theme, and the last one's a mustard. The first case is a hypoplast 70 kilo 19-year-old. He was status post-Fontan in 2010. He has severe dysfunction and moderate AV valve regurg. If any Fontan is referred to a heart failure physician, this is the one that they think they could help the most likely. He was on milrinone, sensitive to diuretics. And this is a kid that did okay on milrinone, but he really wanted to go home, and he wasn't able to eat. And so he was really frail, and we felt like he would do better if he got better nutrition before he went to transplant. In the US, we probably could have transplanted this kid, well, he's an adult criteria, pretty quickly. But we felt like he would be much better off if he was able to get home, get stronger, and eat. And so we did put a VAD in him. We did a HeartMate 3. Some of the pre-VAD workup I've mentioned, but just to put it all on one page, thinking about CT with contrast, where's it going to go? How's it going to fit? Not always necessary, but something to think about. We always look for liver lesions just to make sure before we put in their VAD. We think about collateral burden a lot because we will set our pump speed potentially higher if we think they have a lot of collaterals, and we'll know going into the OR, at least when we walk in, we think, okay, what is this patient most likely going to need? And so some of our patients come out running at 8,000, which is an amazing amount of RPMs. Most patients in like the dilated range are at 5,800, just to give you reference. And so if they have a lot of collaterals, we'll know we think we're going to be running them higher. Finding out if there's a fenestration already, or you think you're going to make one, or you think you need one. And then, as I said, calculating your flow requirements. We start discharge planning before they go to the operating room, just so that they know exactly what it's going to look like to get out of the hospital. The hemodynamics in this kid, he had an index of 2, an EDP of 15. So once again, very exciting for a heart failure physician to see that EDP and think that we could help by unloading with an SVAD. Fontan pressure was 17. That came down nicely when we put the VAD in. No fenestration was seen, so it was decided to make one, and moderate amount of collaterals. This is the kid that did come out with an index of 6. And slowly we were able to start coming down on his flow. His fit study, this is just kind of what this looks like. I mean, everyone has their own way to do this, but we do use the CAD file to try to see where the inflow is going to hit and if there's anything else that needs to be done. And then thinking through making sure their liver has no nodules or that need to be biopsied, because you definitely don't want to have to biopsy a liver nodule when you're on anticoagulation on pump. We also look for thrombus in the ventricle just so that it can be cored out. Fenestration we've talked a lot about, so I won't talk too much. I will say that SVAD Fontans do like their blood pressure higher than the dilated cardiomyopathies. And that's probably because if you venodilate them, of course, they're not going to get good flow back to their SVAD. And so I don't put them in any blood pressure medicine. They're not on any antihypertensives. And they seem to do best like that. They're less symptomatic. And so the couple Fontans we have out right now are just on Coumadin. They're not on aspirin. They're not on any blood pressure medicines. And so from a cardiac standpoint, they're really not on any medications. For the dilateds, we're always thinking about recovery. And so we do have them on all the heart failure medications, but not necessarily for Fontans. Post-operative care, I've mentioned the blood pressure. Early extubation, I'm going to show you something that's really dramatic for a VAD person. Anticoagulation, we just use, now we are using bival in our Fontans for the bridge, and then Coumadin. They could also go to apixaban. That's been showing good results, but no aspirin anymore. So this is a post-extubation Fontan after an SVAD. So what you're looking at here is the flow is the purple. So this is the one you're going to want to focus on. You can see the flow is about 6 liters per minute, and we extubate the kid, and his flow without changing anything is able to go up dramatically. And so the story of this is that, and his PI comes down for those bad people in the room, is that we were really worried about this kid. We were really worried that the inflow was obstructed and he wasn't getting enough flow through his VAD in here. Like, we thought he needed more. So we thought about taking him back to the operating room to redo the inflow or rearrange how the VAD was sitting, and decided, let's just extubate him and see what happens first. And it was a risk that we decided to take as a team. And you can see here that once we extubated him, that flow, he didn't have to go back to the operating room, and he filled just fine. So I think this is pretty dramatic, but a pretty good story of how extubation helps your Fontan patient post in any case, but especially with a VAD in, you can actually see it so nicely. Questions we often get, we talked a lot about, so I'm just going to skip this. The second case I'm going to do is only a couple slides, so we're almost done for questions. This is a 47-year-old actually, I'm sorry, that didn't get changed. He's a mustard DTGA. That's a technical issue. Who was 80 kilos, had many hospital admissions for heart failure, failing systemic ventricle, CVR was 6. He drank and smoked, but had a job and 4 kids, and definitely didn't wanted to live, but wasn't a transplant candidate. So we did put a VAD in him. He is now 57 years old. He's been on VAD this entire time. He continues to chew tobacco, so has not chosen to stop. So he was not a transplant candidate at this time. He feels like he's doing fine with VAD. He's got his kids through high school, and so he has not gone to transplant. Sorry, I missed it. I think the biggest point for this patient, the mustard, is that there's nothing really technically that different about his VAD. It is put on the right side of the chest, obviously, because he's a transpo. And so you can hear the VAD a lot more in a mustard. He hears it more in his ears. It kind of rings. He feels it sucked down differently than we would do in a normal anatomy. So he does, and you can kind of feel where it's positioned in his chest differently. But other than that, for the mustard, we haven't seen a lot of differences in how we manage them, because you're a 2 ventricle, so you're monitoring the subpulmonary ventricle, you're supporting the systemic ventricle. Not a lot too much to be done there. I think the biggest thing for this patient is thinking through the collaboration between pediatric and adult care. And this is a 47-year-old. Every program is going to have a different way to do this. Like, are they done at the pediatric side? Are they done on the adult side? Who's managing what? And for us, we implant on the pediatric side and hope to get them to the adult side. This is a patient who we really didn't have a good system for getting him cared for outside of the pediatric center. So even in his mid-50s, he's still at the pediatric center. And then thinking through where is complications best treated. And we've had a lot of learnings from this and how to work together with adult care providers. And so I think that's the biggest thing from this case that is important learning. For the Fontans, there's lots of hemodynamic learning. For the other congenitals, I think it's more team and how to do that. So just a summary slide. The takeaways, I really think referral timing is important, and we've got to figure this out as a community. We don't have enough patients to just learn by ourselves. So, Action was built just to try to figure this out. And so we would love thoughts and advice about what other institutions we think we should do, research projects, what devices are coming down the pike. And then thinking about using your device as a tool to treat heart failure and not necessarily worrying about it being a bridge to transplant. So I think if you decouple those VAD and transplant, we might be in a better place for adult congenital in the future. That's just more kind of a concept that we should work on as a community. I think that was my last slide.
So thank you very much, Angie. So a great talk, excellent review, and actually very exciting that we have something to offer to these patients. So if you have any questions, either just raise your hands or write them in the chat. So I suggest that Dr. Marshall has a question, so you can unmute your microphone and just ask the question.
Really quick, you can take over screen share if you want, because I can't.
Yeah,
I can't get rid of it.
I will take it.
Okay, thank you. Just so it's gone.
Yeah.
Sorry. Go ahead.
Thanks for a great talk, a great overview. Appreciate your time. You briefly mentioned earlier about CardioMEMS, and I've read some stuff that Dr. Morales has written about using CardioMEMS in patients with Fontan after VAD. But in terms of how you use it, how it helps you, would love to hear that information if you can.
Yes. We've used it a lot. We've used it more in our dilateds. We haven't used CardioMEMS in our Fontans with VAD as much. I'm not sure it will be as helpful. With the dilateds or the 2 ventricle hearts, it has been helpful to titrate your RPMs just to a good, obviously, PA pressure. The Fontans, I don't know yet. It's still unknown if we think that it's actually as helpful. Their PA pressures are just a little bit more difficult to titrate. I don't know if you have put one in without a VAD, when a Fontan probably. It just depends on the patient. So in a dilated, I would say CardioMEMS is very helpful. The one thing you have to think through about CardioMEMS and any VAD implant is when you want to do it, because you don't want to do it right prior to the VAD, because you'll have to take them back to the cath lab because the flow changes and recalibrate. And so I think it's probably best to do CardioMEMS after your VAD, after a little bit of time. So everything's, solved, everything's looking good, and use it more as a long-term monitor of titrating your RPMs at home, so you don't have to keep redoing caths and that kind of thing. So my sense is that we don't have it exactly right yet. I think it's, as I said, more helpful longer term. So our newest strategy is that we'll be putting CardioMEMS in later after VAD if they don't already have one. If they already have one, fine, we'll use it. We'll take them to the cath lab and calibrate it after their VAD. If they don't have one and we want one, we're going to wait a couple months, take them to the cath lab, calibrate it at that time, and use it moving forward for changes in RPMs, not in that immediate post-op period. The post-op period is complicated by having to take them to the cath lab, but also, getting them to lay on the pillow and getting the wand and everything else that you're trying to deal with some other things. So that's kind of my take on it. I think not everyone gets one by any means, and especially the Fontans. We have not necessarily put them in everybody.
Thank you. Amir?
Mm-hmm.
Hi, Angie. That was a great
Hi,
talk. You're definitely, kind of shown us the breadth of experiences in Fontans and ACHD groups with the MCS. We came close to putting in another TAH in a Fontan. We kind of got a little scared away from it as well, and ultimately the patient and the family decided not to proceed. But we went through all the virtual fit testing and got ourselves kind of, I think, mentally. Well, I won't say we got completely mentally psyched up for it, but we were getting there. But it is I think because of the nature of the TH, you get a little worried about how this is going to go. And this is a bit of a Broadway question, but what are your kind of personal insights on, is that those concerns kind of founded or unfounded? I think we have a lot more comfort with, systemic ventricular dysfunction or systolic ventricular dysfunction in a Fontan with a HeartMate 3, or even, a smaller kid with a Berlin. But I think just doing the whole TAH process in a combined failure patient always seems a little more fraught with concerns.
Yeah, I mean, I think you really have to think there's nothing else. 1, 2, Syncardia there's only, I don't want to misquote, but I want to say last year they only implanted 30 across the world. So it's not something that, I mean, they've definitely had good clinical support and lots of support to us when we need them, but it's not probably a sustainable device that's going to be around forever. So I say that because I don't know that it's going to be our answer for the future, that Syncardia is always going to be available. And we don't have another artificial heart. So right now we would potentially do it, but we usually think of some other option for many reasons, all the reasons you said. Our Syncardia dilateds have done great and they get to transplant fast, but all the bleeding with Syncardia with Fontan, I think, is not to be appreciated. I mean, these are all things you've thought about, Amr, but I think it's a lot. And if you can do anything else, in the US, that size kid, if they were a Fontan on drips, they would be a 1A and they would go pretty quick if they're an adolescent. So we may not necessarily have to do that. We have a lot of kids that aren't going quick, so our babies are taking years on Berlin. So it's not everyone, but how the allocation system is set is I don't know that we would do a Fontan Syncardia right this moment without trying to transplant them first. which is usually very anti-Cincinnati, but I just feel like I don't know necessarily that it's a perfect option, especially if they don't have 2 valves, AV valves.
Right. Great,
Thank
thank
you.
And they're never big enough, right? I mean, they're always like a little bit on the small side, and then you're trying to fit it in, and then they have collaterals, and I don't know. I just don't think it's perfect yet.
Yeah.
Or going to be
Kate?
the answer in the long term.
Thank you. So Kate?
Thank you. Thank you so much for an excellent talk. That was really, really interesting. I just have a small kind of specific question. Obviously, we're titrating RPM speed in VADs in biventricular models to septal geometry. How are you titrating it, particularly in that early period? I mean, you've mentioned like sort of chasing some really high speeds, but what do you use practically? Is it just Fontan pressure? Or?
So I love to talk about this because even in the dilateds, I try to use the information that's given to you, which a lot of pediatricians don't. But trying to use the PI and the PI events and really understanding PI for that specific patient. And so I do titrate RPM to the PI and events, and I usually get them to have some events so that I know they're sucking down and then come down a little bit. I also do echo in the OR to see that the aortic valve is, where it's opening, where it's not opening. And I don't let it open, and haven't seen a lot of AI because I think flowing them fast and high in the beginning is good for their end organs. Granted, not everyone's going to tell you they have the same experience, but so I titrate to PI events. I rarely do echo just because once I see the geometry in the OR, I kind of know what I'm dealing with. And then we do cath them at 3 to 6 months just to make sure that we were kind of right and that we have the right RPMs. And then that's really how we titrate. But some people say put a sticker over the PI and don't use it. And I don't think in the HeartMate 3 that's necessarily, I think it actually gives you a lot of information if you understand it and really learn it.
Thank you. That's very helpful.
So I have if there's no more questions, or well, if you have more questions, please raise your hands or write in the chat. But I have a couple of questions just before you go.
Sure.
So this is one of the, as you said, all of us that do heart failure want to have the Fontan that comes with awful ventricle, and then okay, yes, BAT is there.
Yeah.
So
Like, I can help.
my question, yeah, that's the perfect one. That the unfortunately in adults is not the patient that we have more often, as you know.
Yeah.
So what is your cutoff of ejection of systolic function? Of course, is with all the caveats of giving a number in a single ventricle, but many of these patients have mild, moderate systolic dysfunction, and just a lot of diastolic dysfunction, but not a perfect systolic function. So what is your approach when you decided, knowing the extreme LVD system single ventricle dysfunction, which is that clear? So just on those middle ones that you don't know if a BAT is going to help or it's not going to help, or what is your approach to those?
I really like to look at the dimensions of the ventricle too. If you have mild systolic dysfunction, but you're big and dilated, or you have some dilation, and that inflow is going to fit, and you can, because you're not going to be able to run as high of RPMs because you're going to suck down if you don't have dysfunction. You want that baggy ventricle. So I think we'll look at how dilated the ventricle is and see if we feel like we could run at 6,000 and we wouldn't suck down. So some thought process into the dimensions and the geometry if they don't have severe dysfunction. But it is true, it's a really hard thing. Also the EDP, if the EDP is high enough that we think we can run at a lower speed and actually offload it enough. But if the EDP is, 8 or 9 and the function doesn't look that bad, it's just not going to work. It's not going to help you. You're only going to get a couple millimeters of mercury downstream that you're going to decrease it. We recently, well, it's been about a year, we implanted in one that had normal systolic function, had diastolic dysfunction, and his VAD worked really well despite the fact that we didn't think it would. It unloaded the ventricle and the Fontan pressure by about 5 millimeters of mercury. He ended up passing away after a month of actual liver disease. I mean, he became encephalopathic. So he was way too far gone from an end organ standpoint, and we knew that he really wanted to try. Went ahead with it. But interestingly, it looks bad in the data as like a patient without systolic dysfunction, and he was our only one that died. But he didn't die because the pump didn't work, actually. And so I do think when we look at the data, it's really hard to know, when we sparse it out and say systolic dysfunction versus non, and the nons don't do very well, is it that they just had more end organ dysfunction and it was a different group of patients? So I'm not sure that it's not going to help. It's just that by the time they get to us and they have normal systolic function and it's all the end organ dysfunction, I'm not sure how to like parse that out. So that was a long answer to your question. I think
no, but that's actually it's the same thought process, but that's very helpful. So we have time for one more question. I was gonna give it to Isabel that just put her hand up. So Isabel.
Hi, thanks so much for your talk. A lot of what you said really resonated with me. I'm an adult congenital cardiologist in Northern Alberta, and we had exactly the same experience that you had just described with your putting a VAD in someone with normal systolic function, that their liver just went off after that and they didn't make it out of hospital. So I think we have to be really careful about, and our VAD people said exactly what you said. Oh, but the VAD is working well, but the outcome was patient died. So we have to be really, really careful about enthusiasm. But I really appreciated your talk, and I think that the work you're doing is incredibly important. What are some hard stops for you, like that patients that you would absolutely not consider a VAD? And a lot of our Fontans are in that normal systolic function, and a lot have ascites and high cardiac output, low SVR. And our VAD team is quite enthusiastic about helping them, but I'm curious what your thoughts are. Like, what are some hard stops for you?
Yeah, I think it's the liver. I mean, I think knowing if they have significant ascites and not systolic dysfunction, are those the patients that are not going to do well? I mean, this patient had encephalopathy and actually went into a coma. His VAD was beautiful, and so I don't think that those patients are all going to be well supported, or like it's going to work out well. I think if they have such significant liver dysfunction, I think those are our patients that we shouldn't be implanting. And obviously there's a whole field and there's a whole talk on FALD, but that's not right now. But like, what is significant? Like, how much is too much? I think that's what we're going to have to learn. And there's a lot to go into research about, can we reverse it with VAD? Well, we can't reverse the real bad, but how bad is too bad? And, how much can we offload so that the liver gets better? I don't think we know that yet.
So I could keep asking you questions forever because I have many questions, but I think that the time is up. So, and I just really want to thank you for the job, the work you are doing. I think that honestly, you are leading the field and giving a lot of hope for these patients. I think what I would summarize is we have something now for Fontans that definitely works, but a lot of work to do to know what other patients we can help, how much we have to learn about the liver and those patients that have systolic or mildly impaired, normal systolic function or mildly impaired systolic dysfunction. So, I mean, a lot to learn, but a lot of hope. And thank you very much for the work you're doing, for joining us today, and for excellent talk. And to you guys, thank you for joining us, and see you here in 2 weeks' time. And good morning, good afternoon, or good evening, wherever you are in the world. Thank you, Andy. Thank you very much. Bye-bye.